It happens with terrifying speed. You feel a sudden, violent, stabbing pain in your flank, the area on your side, just below your ribs. The pain is so severe that it wraps tightly around your stomach and sometimes shoots directly down into your groin. You are sweating, you are nauseous, and you are absolutely convinced that you have a massive kidney stone. You rush to the emergency room. The doctors immediately order blood tests, urine tests, and a computed tomography scan of your abdomen. A few hours later, the doctor walks into the room and gives you shocking news. Your kidneys are perfectly clear. Your gallbladder is fine. Your appendix is normal. They discharge you from the hospital, tell you to drink more water, and prescribe basic painkillers. But the stabbing, burning pain in your flank refuses to stop. If you are trapped in this terrifying cycle of emergency room visits and negative test results, you must listen very closely. You are not crazy, and your pain is not a medical mystery. You are simply looking at the wrong biological system. Your internal organs are perfectly healthy. You are likely suffering from a crushed spinal nerve, and today we will explain exactly how a hidden failure in your mid-back perfectly mimics the agony of a kidney stone. To understand why your stomach and flank are in agony when the actual problem is located in your spine, you must understand the mechanical engineering of your skeletal system. Your spine is not just one uniform tube. It is divided into very distinct mechanical zones. Your upper back, the thoracic spine, is highly rigid and inflexible because it is firmly attached to your rib cage to protect your heart and lungs. Your lower back, the lumbar spine, is highly flexible and designed to bend and twist. The most dangerous mechanical stress point in your entire body is the exact location where the rigid thoracic spine meets the highly flexible lumbar spine. We call this the thoracolumbar junction, comprising the T10, T11, T12, and L1 vertebrae. Think of this area as the main hinge on a heavy door. Because it absorbs massive amounts of rotational stress every time you twist your torso, the spinal discs and the facet joints in this specific transition zone wear out and degenerate very quickly. When a spinal disc herniates or a joint becomes severely arthritic at the T11 or T12 level, it clamps down on the exiting electrical cables, the nerve roots. These specific nerve roots do not travel down your legs. Instead, they exit the spine and wrap horizontally around your body, traveling across your flank, over your hip bone, and terminating directly in your lower abdomen and groin. When the nerve is crushed in the back, the brain receives the distress signal and assumes the front of the body is being damaged. The organs are safe. The electrical wire in the wall is being actively crushed. This anatomical overlap is responsible for catastrophic medical mistakes. Because the pain manifests in the abdomen and groin, general doctors and urologists focus entirely on internal organs. They spend months chasing ghost diagnoses. They order endless ultrasounds to check the kidneys, liver, and intestines. When everything appears normal, some doctors will even diagnose the patient with irritable bowel syndrome or pelvic floor dysfunction, prescribing heavy digestive medications or nerve depressants. The hidden danger here is extreme. We have seen patients who have actually undergone unnecessary abdominal surgeries, having their gallbladder or appendix removed, only to wake up from the operation with the exact same severe flank pain. You cannot fix a crushed spinal nerve by removing a healthy abdominal organ. Furthermore, general physical therapy aimed at treating core spasms will do absolutely nothing if a hard, calcified bone spur is actively suffocating the nerve cable deep inside the spinal canal. We must change the focus from the organs to the neurological wiring. We cannot solve this mystery by pressing on your stomach. We must act as elite medical detectives. First, we differentiate between organ pain and nerve pain using clinical logic. True kidney stone pain typically comes in intense rolling waves, known as renal colic, and is often accompanied by dark or bloody urine. Spinal nerve pain behaves differently. Nerve pain is highly positional. If your flank pain sharpens when you twist your torso, bend sideways, or arch your back, it is almost certainly a mechanical spinal problem. To find the objective truth, an elite neurosurgeon demands a high-definition magnetic resonance imaging scan. But here is the ultimate diagnostic trap. When a patient complains of back pain, a local doctor usually orders a standard lumbar MRI. A standard lumbar MRI starts at the L1 or L2 vertebra and scans downward. It completely misses the thoracolumbar junction. The doctor looks at the scan, sees a healthy lower back, and tells the patient they are fine. The camera was simply pointed too low. We must explicitly order a thoracic and lumbar MRI to capture the critical T10 to L1 transition zone. When we evaluate the correct MRI, we look closely at the axial, top-down view of the T11 and T12 nerve tunnels. We must determine exactly what is causing the short circuit. Is it a herniated disc pressing on the nerve? Or is it a condition known as Main syndrome, where the facet joints in the back of the spine have become severely arthritic, inflamed, and overgrown? Because the pain perfectly mimics an organ failure, our treatment protocol demands absolute precision. We do not rush to open surgery. First, we perform a highly specific X-ray-guided diagnostic nerve block. We inject a microscopic drop of numbing medication directly onto the T11 or T12 spinal nerve root. If the patient sits up and their severe flank and abdominal pain instantly vanishes, we have undeniably proven the diagnosis. We have found the exact millimeter of the short circuit. Once confirmed, we fix the spine to cure the abdomen. If the facet joints are the culprit, we use advanced radiofrequency ablation. We use controlled thermal energy to safely deactivate the tiny sensory nerves carrying the pain signal from the arthritic joints. If a disc herniation or a bone spur is actively crushing the main nerve root, we use ultra-minimally invasive techniques. Using percutaneous laser disc decompression or precise endoscopic surgery through a tiny keyhole incision, we vaporize the disc pressure or gently shave away the overgrown bone. We physically free the electrical cable. The false electrical signals stop, and the terrifying, stabbing pain in your flank and stomach permanently vanishes. Living with chronic, unexplained flank pain is a psychological nightmare. Patients live in constant fear of a sudden organ failure. They accept this terror because a general doctor told them all their scans were normal. They spend thousands of euros on endless urology visits, unnecessary abdominal CT scans, and dangerous daily painkillers that slowly destroy their healthy kidneys and liver. But let us look at the true cost of accepting a mystery diagnosis. If you ignore a severely crushed nerve at the thoracolumbar junction, it will eventually suffer irreversible damage. You will develop permanent numbness in your abdomen, chronic groin pain, and muscle weakness in your core. You are risking permanent neurological damage or even unnecessary abdominal surgeries because your doctor was looking at the wrong imaging scan. For a fraction of the cost of a single trip to the emergency room, you can have an elite neurosurgeon review your spinal mechanics, potentially identifying the false alarm and ending the panic immediately. If this video helped you understand your pain, please click subscribe. It allows us to keep providing free, elite medical education to patients worldwide who cannot afford a neurosurgeon. You are watching this video because you are looking for a real solution. But you cannot fix a mechanical spinal problem by guessing, and you cannot fix it by treating the wrong half of your body. If you have been cleared by an abdominal specialist, but you are still in agony, do not just accept the pain. Every spine is unique. Click the link in the description to upload your MRI or CT scans to our secure portal. Our neurosurgeons will personally review your imaging, hunt for the hidden compression at your thoracolumbar junction, and build your personalized, minimally invasive treatment plan. Stop living in fear and stop treating the wrong anatomy. Let us find your solution today.